Good morning, everyone. Welcome back. Thank you again for the organizers. So, topic for today's talk for me is incision planning in head and neck cancer surgeries. I purposely not included thyroid, parotid, and laryngectomy since we had a small discussion yesterday. So, we'll go on to some other incisions and how we plan it. So first question would be whether to take a skin incision or not. Per-oral approach can be used for smaller tumors, anterior tumors with adequate mouth opening. And it may even be possible for posterior tumors if it can be carefully executed. And some assistance can be provided with cheek retractors, tongue stitches, mouth retractors, gags, or bite wounds. So many times we can do it without an incision. Pre-operative planning is important to achieve optimal aesthetic and functional results. The healing process causes the wound contraction and scarring, which can compromise function and appearance. The goals are to establish functional soft tissue structural support to give most natural aesthetic appearance with minimal distortion of the healing. To optimize the wound healing environment to avoid infection, excessive contraction, and scarring. So, three factors that has to be considered while planning an incision is the access. Okay, that's the prime thing. We have to get access to what we are going to remove. Second thing should be aesthesis, and finally the vascularity. When we close, it has to heal well. Coming to aesthesis in the face and incisions. The concept lies in 6 major aesthetic units, including the forehead, eye and eyebrow, the nose, the lips, the chin, and the cheek. And there are also additional anatomic subunits. For example, the nose can be divided into nasal tip, dorsum, columella, soft tissue triangles, side walls, and nasal alar regions. So these units and subunits are visual anatomical boundaries where light reflections and shadows along these aesthetic borders help to conceal parallel scars. And we have to evaluate skin laxity surrounding the planned incision. And we should appreciate that there are mobile facial structures like eyelids, nasal alae, nasal tip, auricle, vermilion, commissures, and filtral ridges. And correct orientation of the planned incisions next to these mobile aesthetic facial structures is important to avoid distortion when closing the wounds. Another concept to be considered is about relaxed skin tension lines, RSTLs. The skin tension lines are oriented along the furrows formed when the skin is relaxed. The closer an incision comes to lying within an RSTL, the better ultimate cosmetic appearance of the scar. And avoid making scars perpendicular to the RSTLs. For optimized scar appearance, we have to plan the incisions along these RSTLs. Plan incisions at the border of the facial and aesthetic units like forehead, eye, eyebrow, nose, lips, chin, and cheek. And we have to adhere to the techniques of tension-less wound closure. Avoid wound edge eversion, and there should be a traumatic handling of tissues. Next, coming to the vascularity, that was about aesthesis. To optimize the viability of the flap and ensure primary healing, there are 4 main paired arteries of the face which provide major blood supply to the facial skin. They are supratrochlear artery, supraorbital artery, temporal artery, and the facial artery. And coming to that was for the face, and coming to the neck, again there are 4 vascular regions. The upper neck supplied by the facial artery, the lower neck supplied by the transverse facial artery and its branches, the middle neck by the superior thyroid artery, and posterior neck by the occipital arteries. So with those concepts, what are the deciding factors when we consider any surgical approach? The deciding factors are the site of the tumor, the size of the tumor, the proximity or involvement of the mandible or the maxilla, any prior treatment given, and mouth opening. The surgical approaches can be transoral or a peroral approach, or a combined transoral and transovagal approach can include a lower cheek flap approach, upper cheek flap approach, mandibulotomy approach, a visor flap approach, or when there is a skin involvement, we may have to tailor the approach, the skin incision, to enclose this tumor and take it out. So, what are the incisions and approaches in the head and neck? I'll be mainly going through this incisions, concentrating on the upper face and scalp, the bicoronal incision. In the mid-face, there are the lateral rhinotomy and Weber-Ferguson incision, and the lower face, the lower lip split, and some incisions for the neck dissection. Coming to bicoronal approach, it is a transverse incision that is taken across the scalp. And the principle is that it should be behind your hairline and behind the baldness that could be anticipated in a male patient. It can be taken like this smooth curve, and it can be extended preauricularly in the preauricular crease or postauricularly behind the pinna. Instead of making it in a single straight line, they say it's better to do it with the cuts and triangulations or a wavy pattern. So these two are the two favored approaches for a bicoronal incision. So here we got a patient recently. He came with a incision that was done outside in an outside hospital, and I just want to highlight how it was done wrongly. So this dotted lines you see is the incision that was already there, the scar, and this one is probably the right scar that would have been done. So here, the incision was started way anterior to the preauricular crease. That is one wrong. And then it is crossing over the scalp and going anteriorly, way anteriorly to the opposite side. You can see here, almost transecting the other side. If you raise the flap like that, your superficial temporal artery and all those vascular regions are going to be involved. So, better to stay close to the preauricular crease, close to the pinna, and stay in the preauricular crease, and it can be extended downwards. That won't create a problem. And then come across with these triangulations. So that's about bicoronal incisions. There are many mid-face incisions described, but commonly what we do to get an approach of upper cheek flap is mainly done for the carcinoma of posterior maxillary alveolus or a tuberosity of a maxilla or a maxillectomy type of procedure, or an ethmoidectomy. It's not common nowadays. The incision done would be a lateral rhinotomy incision. The classical approach is Moore's incision. The vertical limb is lateral to the nasal dorsum, and then coming around the ala, then transversely across the lip, and then to split the lip, turning down and split. This is the classically described Moore's incision. So we were finding problems with this incision, and we tried to modify it, and we have published it as a paper titled Aesthetic and Anatomical Basis of Modified Lateral Rhinotomy Approach. What is the difference? Here, the vertical limb is between the dorsal and the medial and the lateral dorsal nasal subunit. Then it comes around the ala, get into the nose. Okay, and there's a small transverse thing inside the nose, like the skin part of the inside the nose. Then it comes out, and then vertically down along one of the filtral So that is the aesthetic and anatomic basis of somebody's muted. Sorry about that. So, the incision we described has its own aesthetic and anatomic basis. Aesthetic basis is that it is designed based on the principles of the facial units and subunits. And anatomic basis is that it has taken into considerations the muscles, the superficial muscles of the face, like procerus and levator labii superioris labii. You can read the paper for the details. So these are some of the outcomes, okay, about the lateral modified clinotomy incision. Now coming to the Weber-Ferguson incision, and this has a lateral extension. This is called a Diefenbach extension, and it also has a lip split. And sometimes if you need it vertically upwards, you can change it to a Lynch type of extension. And this about the lateral lower lid extension, it can be a transcutaneous or a transconjunctival extension. And here we prefer transcutaneous subciliary extension. It can be either subciliary, subtarsal, or infraorbital. Subciliary is coming laterally in the first crease. Subtarsal is below the tarsal plate of the lower lid, and infraorbital is along the it is taken in the crease below the total eyelid. And among this, the subciliary is what we prefer. So these are the some outcomes with subciliary incisions. You can see the scars, which is not much hidden. But this is not the case in all cases. There can be problems like ectropion, lid lag, lid sag, and so on. But these problems are not purely because of the incisions we take in the lower lid, but it is mainly because of the support, the lack of support which we give to the inferior infraorbital region. It should ideally be a good bony support when this incision becomes proper. Now coming to the lower cheek flap approach, it's used for the larger tumors of the oral cavity, marginal mandibulectomy, segmental mandibulectomy, buccal mucosa RMT, and some posterior upper alveolar tumors when we do a mandibulotomy approach for an maxillectomy type of tumors. So lower lip split can be a midline split, midline lower lip split, or an angle split, or it can be tailored along the involved skin. The lower lip split can be a straight midline as described by the Roux and Trotter, or it can be midline with a chin contour, that's called the McGregor's incision, or Hayter modification when we take a V or a chevron into the vermilion margins and in the midline lip. But we usually do this modification as described by Dr. Monique Priakos. This is a midline with an isoplasty at the labiomental crease. This is what we usually do. An angle split splits the commissure laterally and then comes down into the cheek and it joins to the transverse neck crease incision. So that is an angle split. The disadvantage of the angle split is that it divides the commissure and can produce commissure weakness and drooling. And we feel the midline lip split is cosmetically better. This is what we do, and we can see an outcome that is good. But here again, we have not found an ideal incision. Always we discuss in our department how can we modify to get better outcomes.
So there can be problems like chin distortion. So you can see there is some distortion between the halves of the chin, sensory issues. And usually this part is not a problem, but this vertical incision in the neck can be a problem. Here again, we try to design an isoplasty there, but again, we have not found the best way to do it. And then it turns after a 90 degree along the neck for these incisions. So this taut vertical limb can be a problem. Coming to angle lip split, when we do it, an angle versus midline lip split. When the tumor is in the buccal mucosa, when it approximates the commissure, and when the communicating branch of the superior labial to the inferior labial artery cannot be preserved. Okay, I'll repeat. When the tumor is involved in the buccal mucosa and it is approximating the commissure, and when the communicating branch of the superior labial to the inferior labial branch cannot be preserved, we use angle lip split. I'll explain it a little more. So this is a blood supply of the upper and lower lip. This is a facial artery coming from the neck, and it has a main superior labial artery and an inferior labial artery. Okay, so when we raise the lower lip, lower cheek flap, this may be cut. Okay, the facial artery may be cut. So if you want to preserve the vascularity of this lower lip and the chin region, there should be a communication between the superior labial artery and the inferior labial artery, and this communication should be preserved. If you think your tumor is going to, your resection in the buccal mucosa is going to involve this area from inside, then you don't do this. If you do a vertical lip split there, then the vascularity of this area will be affected, and that can lead to the necrosis there. So in such situation, you should take an angle lip split. So that is anatomical basis of an angle lip split approach. So that's a tumor there. Here, if the tumor is like this, your resection will be like this, and then the communicating branch may be affected, and then you have to do this sort of approach. Okay, angle lip split. Otherwise, this can be a problem. Okay, there will be a necrosis of the midline lower lip split. Coming to the outcomes of the angle lip split, it is also not always perfect. It can stand out like this, and then it comes down to the neck, to the transverse neck crease incision. Sometimes we do a mini angle lip split. It is a lip split that is not fully connecting to the neck incision. Okay, we retain this part, and this is usually done when we do a posterior marginal mandibulectomy, when we don't need a full lower cheek flap to be raised, but this mini angle split can provide an access towards the ramus and area, and we can even do if this goes down a little more, you can do a marginal mandibulectomy without a full cheek flap. And this can be done and designed like this when the defect inside is not too big. We can also design a nasolabial flap by doing such a mini angle split. Another design, there's a lot of thought process because we have not found the best way of doing it. Another design we were thinking is to do a commissure sparing lateral approach. Okay, so here it's not exactly at the commissure, but it's little anterior, about 1 centimeter anterior. The commissure is left intact, and then again it comes down, and then around the chin and to the neck. We are not sure whether this is the right way to go, but these are the thoughts. And lastly, about the tailored incision when there is a skin involved. That depends, depending on your skin involvement, how much you want to take the skin, and first you draw the skin marking, and then you think about how it can be connected to the oral cavity like this, and how it can be connected to the neck. Neck, usually it will be a transverse incision, and you can design angle split from interior. Here again, there is a modification of bucket handling. Okay, that's called a buccal handling, meaning that if you put this incision, you may be able to raise an anterior skin flap and a posterior skin flap without making angle split. That's called, you get sort of a bucket handle here. So that's called a bucket handling incision when you do a tailored incision with skin involvement. Now about incisions about neck dissection. So first of all, some concepts about neck dissection. We discussed this yesterday also. The levels to be cleared are generally 1 to 3 or rarely 4, and it is a selective neck dissection. And we usually do an anterior approach even to clear level 5 nodes. Okay, that is a concept that we are introducing. An anterior approach even to clear level 5 nodes. A posterior approach, dissecting the spinal accessory nerve in the posterior triangle is rarely done. We don't do that. But not that we are not fully clearing the level 5 nodes. And this can be even done in clinically positive nodes. And radical neck dissections are rare. There, the approach may be little different. So that's about the neck dissection. And when we consider incisions, the important aspect should be the exposure again, the flap viability, the protection of the carotid artery, and the aesthesis. It should provide the adequate exposure, aesthesis should be good, and there shouldn't be viability issues and no tri-point. Okay, again some problem. Share it again. Okay. I think I'm okay. Okay. So it has to provide adequate exposure, aesthesis, should not interfere with the viability, and there should be no tri-point. And for that, the transverse neck crease incision is ideal. So these are some outcomes of transverse neck crease incision, which we usually take. It never turns upwards towards the mastoid, and never turns anteriorly towards the chin. This is the incised side, and this is her normal side, almost looking identical. Okay, so that is the transverse neck crease incision for neck dissections. But again, this is also not without morbidity. We have described a paper, selective neck dissection oral cavity is not without morbidity. We have looked into 106 cases and found problems with this scar also sometimes, creating hypertrophic scar, lymphedema, skin sag, and so on. So what we found out was the scar outcome. We had 106 patients where this transverse neck crease approach was tried, and the scar outcomes were poor complexion in 14%, poor texture in 23%, limited skin movement in 8%, evidence soft tissue defect in 12%, lymphedema was seen in 13%, poor sensation in about 15% of the patients, facial smile asymmetry, that's not a problem with incision, but was seen in up to 30% of the patients, and constant the shoulder dysfunction we discussed yesterday. So even the transverse neck crease incision is not without problems. And the morbidity was more when the patient gets an adjuvant radiotherapy and when it is associated with a free fluid, like scar issues, lymphedema, sensory morbidity, facial asymmetry, and shoulder dysfunction. Now talking about post-auricular incision, you heard yesterday Vishal Rao talking about the post-auricular approach to the neck incision. That is a very good approach for doing a neck dissection, especially if you are not clearing level 1A, 1B. It's little difficult to come around and to clear 1A, 1B. He was talking about preserving marginal mandibular nerve. So it's a good approach to clear lateral levels, even level 5, especially in thyroid cases. It's usually done for thyroid, and for doing the neck dissection in a thyroid, that is a good approach. And we can get concealed scars, as Dr. Vishal Rao told yesterday. But when we are doing it for oral cancers, and oral cancers are mainly done in males, what we have seen is it most often results in hypertrophic scars. Okay? In males, post-auricular approach, the hypertrophic scar is very common. And of course, as This photo I've taken it from Vishal's presentation. The tip necrosis can occur, but if you carefully plan it, this is not a problem. In females also it's not a problem, but in males we have seen more incidence of hypertrophic scars. And for neck dissection, the incisions which are not preferred are this U-shaped incisions. No, it's not. For doing a selective neck dissection, even clearing level 5, we don't need to turn it up to the mastoid. We don't need to turn it up to the chin. Okay. This incision is not preferred, and even this incision is not preferred. We don't need to go like a U towards the mastoid. This is a McPhee type of incision. Again, if you want to do a McPhee, do it in an upper crease and in a lower crease. Don't turn it like this, like a U or a V. These incisions are not preferred. And even this classical Kreil's incision is not preferred. Even large nodes can be cleared with a transverse neck crease incision. Again, I think I got disconnected. It's okay. I know how to do it. Yeah, that. So even this incision is not preferred. If you need to for a large R&D type of neck dissection, you may have to put a vertical limb to clear fully the lower posterior or a high level 5B nodes. But then you have to design it in such a way that this tripointer is not coming across the line of the carotid artery. So such incision where the tripointer comes along the carotid artery is also not preferred. And lastly, about the sentinel node biopsy. So this is an approach which we have started doing in our department, and this is an approach that is via media between observation of the neck and classical selective neck dissection, where we find out the sentinel node and we just do a sentinel node biopsy with this cute little incision about 4 or 5 centimeter, and the whole morbidity can be avoided. So sentinel node biopsy should be the thought process in adequate and appropriate patients where resources are available. Thank you.
Thank you, sir, for that nice presentation. As you aptly pointed out, sir, the good incision one, which gives you good access, good aesthesis, as well as retains its vascularity. Any questions from the audience?
Nice presentation, Dr. Krishnakumar.
Thank you.
What are your tricks? I think this is not tricks for preventing scar hypertrophy and keloid formation, especially when you are doing a lip split procedure.
Okay.
And the problem is from the cartilage, thyroid cartilage to the chin point. That is the area where we have seen a lot of scar hypertrophy. So what are your tricks which you can?
By and large, it is due to the nature of the skin. Okay, it cannot be prevented. Patients are usually prone for such type of hypertrophic scarring. But to some extent, it can be prevented. Mainly is to avoid vertical scars. I told you it should be a transverse scar. Vertical scars are probably becomes taut and straight. And adequate, the incision care after the incision has to be given. Usually taking out the stitches as early as possible by the 5th or the 7th day. And we usually apply, some ointments like contractibles or like some silicone gels and asking them to do a gentle massage over the incision. And better approximation and avoidance of handling of the cases. Sometimes in order to get access, we make a small incision and then stretch it very badly. And all those things can produce scars. But hypertrophic scars in general are the nature of the patient's skin. So that factor cannot be prevented. But then sometimes that can be anticipated. Suppose suppose if there is a hypertrophic scar history, you can plan it to get it, take your incision in a concealed.
Dr. Thankappan, you have told all the incisions is very nice, but the classical book description, a Schobinger's modification, especially the beginners of doing a neck dissection, is always advised because to get a good exposure and avoiding the 3-point junction at the carotid bifurcation, that is one. What's the role of is McPhee's incision in a salvage neck dissection? That is one. And hockey stick incision for the lower level 3, level 4 rods, and a reverse hockey stick incision for the submental submandibular area. Why you are against of all these incisions?
No, these are all classically described, sir. Okay, we will get a huge exposure, but adequate clearance, these are not required. These are not required. But if you're teaching the juniors, you stand behind them and take them through how selecting neck dissection 1 to 3 can be done through a transverse neck. It can be easily done, but they have to be given the training. At the beginning itself, you say you take a big incision and clear it. No, it's not the right way. That's not our thought process. Even when the first year resident comes, we make sure that they should not take a big incision to get it clear. So those are all old concepts. No, only a transverse neck incision. Yes, except where if you want to clear a lower level 5B, okay, there it may be a difficult problem. Then you can do a McPhee type of incision, meaning that you can put 2 incisions, but that too in a transverse neck crease incision. The 2 should be in a transverse neck crease incisions. There is no need of turning the incision, taking the chyle incision, putting a vertical is not required. Of course, it is a little bit challenging for the beginner, but the beginner has to be taught.
Just a point. I do agree with what just Nicky said, that a single transverse skin crease incision, we can do a 1 to 5 neck dissection, actually pretty comfortably. What we need to plan is, we have to see which is the skin crease that we need to choose when we plan to do this. Because sometimes the patient may have more than 1 or 2 skin crease incision. Now, if you are only going to do a 1 to 3, then maybe we can choose the 2 finger, the usual teaching, but then we don't have to curve it, anteriorly or posteriorly. If we want, we can just extend it along the skin crease,
yes,
towards the opposite side to increase the exposure to 1A, and posteriorly along the skin crease to have that level 5 dissection. So we can very well do a 1 to 5 neck dissection with a single transverse skin crease incision, and we can increase the length of the incision depending on what extent of neck dissection we need to do. Having said that, there is a role for all the incisions that you just mentioned, but not in all cases. Many times we do get patients where there is a 1B, some swelling is there, a biopsy is done, and this incision is taken way up, almost at the level of the lower border of the mandible. And let's say a submandibular gland, it comes as a intermediate or a high-grade adenoid cystic carcinoma, and they just done an excision of the submandibular gland. Now you have to go back in and do at least a 1 to 3. Now, do you take the same incision, or if the patient has a positive note, can you do a 1 to 5 in such a situation? That is where we can modify the incision depending on what the need is. And McPhee's incision can be still done, because doing a 1 to 5 in a McPhee in a salvage setting, post-RT, it may be difficult to get the exposure. There, McPhee incision will increase the exposure better. So, we need to train the residents, as what KK just said, and from the beginning, early on itself, we have to tell them when to do what, rather than asking them to do everything with that same incision.
Yeah. If you give them, you're a beginner, you do this, they will never change.
Yes.
Starting from the first case, they have to be taken through the right way to do it.
Kiki, you said that you'll do some silica gel still. So is a gel useful, or like some, also they mentioned there are some silica dressings.
Dressings are also available. Yeah. It prevents this, I think the skin stretching, the scar stretching.
Okay.
Those are just plastic surgery principles. We are lucky that they are all with us.
Right.
So
But not that all our cases are going perfectly well. I was showing the practice.
All right. So that paralabial incision that you were showing, you said the angle of the mouth, incision going down. So that, I think if you take like a step ladder incision, those heal better than just a regular scar down.
Yes, that may be a good suggestion. Yeah. Even we also think about the alterations of angles and even with like lips. Yes.
Now, we also agree that the posterior cut incision is not necessary most of the time.
Yes.
For example, when you're doing a wide field total laryngectomy, if there is a positive node on one side, we always put a posterior Sorensen a little wider compared to the ipsilateral side. We can do the comfortably R&D, even if necessary, even MRND.
Yes.
I agree. It depends upon the neck, short neck, stout neck. Suppose a patient who is having a long neck, little bit difficult. Of course, there is no need of putting a posterior cut incision most of the time.
The upturn is not required. You can go posteriorly how much ever you, but don't turn it upwards
Towards the mask side.
The classical
But,
black Sorensen, you don't need.
Classical textbook, like even McGregor, he says include the part of the scalp for the better vascularity of the upper lip. That's how he describes.
I think we need to change. Those are all myths.
So so transverse is a great incision, but when we start raising the flap, since there are no landmarks, so especially when you're raising the 1A region, as juniors, when they start doing a transverse incision, then you have to be really careful how they raise that part, and that's the area as beginners, we as trainees have buttonholed that area.
Correct.
The trick is to identify platysma top and also contralateral platysma and join that plane between the platysma. This thing. That is the area where when you do a horizontal incision, you buttonhole that skin in the anterior part.
Juniors have to be